the complexity of our work has seemed to exceed the ability of even our specialists. What the experts we'd gathered recognized, however, was that we in medicine are not the only ones to have faced this problem. In the aviation is one. On October 30, 1935, the U.S. military held a flight competition for airplane manufacturers building its next generation long-range bomber. And this was expected to be the winning design, the Boeing Corporation's Flying Fortress, so called because it was the first plane with 4 engines and a 100-foot wingspan, and therefore it could fly farther and faster and with a larger payload than ever before. But 300 feet off the ground, the plane lost control and crashed in a fiery explosion, killing its crew. An investigation revealed that nothing mechanical had gone wrong. The crash had been due to what they called pilot error. It turned out that the 4 engines made the plane substantially more complex than previous aircraft, requiring the pilot to manage settings for each engine, plus retractable landing gear, wing flaps, the pitch of each propeller. The pilot had forgotten to release a new locking mechanism on the elevators and on the rudder controls, and so it crashed. The military canceled plans for the contract with Boeing. The airplane was deemed too much airplane for one man to fly, and Boeing nearly went bankrupt. Still, the Army purchased a few aircraft from Boeing as test planes, and some insiders remained convinced that the airplane was flyable. So the pilots got together and considered what to do. Instead of demanding more training and more specialization, after all, it was their top test pilot who had flown and crashed that plane, they came up with an incredibly simple tool. And this was the crash as it burned on the floor on that ground in Dayton, Ohio. They came up with an incredibly simple tool against this. A pilot's checklist with a simple step-by-step set of checks for takeoff, for flight, for landing. And with it in hand, the pilots flew 1.8 million miles without one accident. And the checklist became the backbone of modern aviation safety. A couple years ago, a Johns Hopkins researcher here named Peter Pronovost brought this insight into physician practice, creating a checklist for a very ordinary procedure. And this is the checklist he started with, for the insertion of a central intravenous line in ICU patients. The checklist was absurdly simple. Its steps could be found in textbooks going back decades. Doctors should make sure they wash their hands, clean the site for the line, sterilely drape the patient, put on a hat and mask and glove and gown, and then apply a sterile dressing when they were done. But the team found that doctors missed at least one of those steps in 30% of patients. And when Michigan introduced this checklist into their hospitals, their infection rates dropped 2/3 in the entire state. 1,500 lives and $200 million were saved in the first 15 months. Our experts saw this and asked whether we could do the same thing for operative care. So they put together what has become, with careful piloting and lots of revision, the WHO Safe Surgery Checklist. They built it with 2 aims: simplicity and impact. It seeks to ensure that we in surgery make sure we have the correct patient for the correct operation and follow established approaches for reducing deaths and complications from unsafe anesthesia, from preventable infection, from bleeding and lack of teamwork, the leading killers in surgery. Before the patient is put to sleep, for example, The team has a few seconds where they pause and have to sign in to make sure they've checked that the patient does not have a problematic airway and that they have appropriate intravenous access for resuscitation if there should be significant bleeding. Immediately before incision, they take a timeout to make sure that everyone in the room knows each other by name, that the surgeon has discussed out loud how much blood loss is expected and whether any unexpected steps might occur. And the team confirms that antibiotics were given in the right time frame. Before leaving the room, the team will have a sign out and, among other things, agree upon the plan to be followed in recovery. Each step is aimed to take no more than 60 seconds. This spring, we introduced the checklist in our sites around the world. And we have some preliminary results from the first 1,000 patients in whom the checklist was used. Already we've seen the miss rates for those 6 critical safety steps drop by half, from 64% to 32%. And the sites are climbing the learning curve of how to use the checklist, how to convince everybody it's worth using. And already a couple are approaching 0% failure. Although we can't quantify the change in the outcomes yet, the confidence intervals after 1,000 patients are too large. We've already seen a statistically significant and substantial reduction in complications and deaths, all from a simple checklist that costs almost nothing. You're going to hear today from some of the pilot sites about their experiences with the checklist, and you're going to hear from major professional organizations and even entire countries which have come to see in this simple idea a transformative possibility for the care of patients everywhere. The goal is simple: to turn the knowledge we have of how things ought to be done into actual behavior, and by doing so, save lives. As surgical volumes explode around the world, we need to help patients everywhere, from London to Lesotho, from New Delhi to Nashville. We need to help them everywhere receive high-performance care. And we now have a glimpse of how it might be done. Thank you.